Good evening, everyone. Good evening, all doctors who have joined in this Zoom platform. This is a monthly online webinar series of IMA AMS Kerala State Branch. This is the 7th webinar we are conducting in this term. And we usually conduct monthly online updates, online academia series, which we upload in the social media sites of IMA Kerala State Branch. And in this, today we have a different topic, that is aortic dissection, a rare cause of chest pain. And we are indeed privileged to have two eminent speakers, HOD of Professor and HOD of Department of Cardiology, Government Medical College, Trivandrum, and Professor and HOD, Department of Cardiovascular and Thoracic Surgery, Dr. T.K. Jayakumar of Kottayam Medical College, are with us even in spite of their busy schedules. And our state president is here always supporting AMS in all the programs. I welcome our beloved state president to this meeting, Menon sir, to this meeting. I welcome the speakers, Dr. Matthew Ibe and Dr. T.K. Jayakumar, to this webinar. And to moderate this session, we have Dr. Manu Basi, who is also faculty of Department of Cardiovascular and Thoracic Surgery, Government Medical College, Kottayam. I welcome Dr. Manoop to this webinar. And the convener of AMS, Dr. Vinod Nair, is there, and Dr. Joju Pomson is there. All eminent leaders of IMA Kerala State Branch who are present here. I welcome all of you and welcome all the online participants. May I invite our beloved state president to say a few words. Menon sir, please.
Yes, good evening, Dr. Deepa, Dr. Vinod, Professor Dr. Matthew Ibe, Professor Dr. Jayakumar, and the moderator, Dr. Manu, all senior leaders and dear friends. This is basically an academic session. I don't wish to go with the long talks here. The topic is highly relevant, aortic dissection, and the seriousness and the emergency nature of the situation everyone knows, and what are the latest the management, everything. We have got wonderful speakers, experts, the cardiology professors from government medical colleges here to address us. So I think I should also congratulate Deepa and Vinod for taking care of the AMS as such and conducting regular programs, highly relevant for the occasion. Usually we had sessions on fever and all relevant topics we were having so far. And I just wish that you keep it up like that. At the epidemic time, we have to conduct more webinars on the infections, and we are going to get some guidelines from the government sector as such, health service. Then and after that, I think we'll have regular sessions, a few more on the endemic or epidemic activities. So let me welcome all of you once again for this session. And I just declare that this academic session is inaugurated. Let us have a fruitful session. Thank you very much.
Thank you, sir. And now we'll go straight away to the session. We have Dr. Manu B, who is the Assistant Professor of Department of Cardiovascular and Thoracic Surgery, Government Medical College, Kottayam, as the moderator. He graduated from Amrita Institute of Medical Sciences in 2004 batch and had his MS General Surgery and MCH Cardiovascular Thoracic Surgery from Government Medical College, Trivandrum. His areas of interest are aortic surgery, minimally invasive cardiac and thoracic surgery, and chest wall surgery. I now hand over the session to Dr. Manoop. Dr. Manoop, please.
Thank you, ma'am. Thank you for the kind introduction. Good evening, respected seniors, colleagues, and members of medical fraternity. So tonight we delve into a critical high-stake clinical scenario in this webinar topic. So we'll be discussing on aortic dissection, which is a rare cause of chest pain. From our clinical practice, we have found that it's not so rare. Usually it is a misdiagnosis, and most of the time, unless and until it's a watchful eye that is taking care of the patient, sometimes we get misdiagnosis. So, guide us through this complex topic. We are privileged to have two exceptionally distinguished faculty members who are like literally the giants in their own respective fields. So, our first speaker is Dr. Matthew Abe, sir. So, which we all call Saintly Matthew, sir. So, I did my MS and MCH from Government Medical College, Trivandrum. So, of all the cardiology faculties, whenever as a surgical resident, we are dealt with some issue, or we need an echo or angio or anything. This is one faculty we always use to pester, and we go up to. Sir is very humane consultant, and someone we all very approachable. So, sir did his MD medicine and DNB general medicine from Government Medical Trivandrum, and did his DM from Government Medical College Kottayam. And sir has done his FRCP London, and sir's primary area of interest is interventional cardiology and clinical cardiology. So, sir will be setting the clinical foundation for us tonight. And following sir, we will hear from our second speaker, Dr. Jayagumar sir. He is the professor and head of department, Government Medical Cardiothoracic Surgery, Government Medical College, Kottayam. Sir will be sharing sir's immense surgical perspective on managing this acute emergency. And also, I would like to acknowledge our esteemed IMA Kerala State leadership for taking this initiative and having a fruitful discussion on this topic, so that doctors and general practitioners from all aspects could be well informed. The whole intent of today's discussion is to introduce and have a concise discussion on aortic dissection, its clinical evaluation, how to diagnose it, and what would be the management. Usually it is said that once you have a dissection, that is the patient is doomed. It's not like that anymore. The technologies are advanced, the surgical techniques are advanced, and we have crossed more than 520 cases in last 5 years. So it's good, it's going good. So I'll without any further ado, I'll invite Dr. Matthew Ibe sir to commence this scientific session. Over to you, sir. We are eager to listen to you.
Thank you, Dr. Manoop. Can you see my slides?
Yes, sir.
Okay. So, respected moderator, Dr. Manoop, my co-speaker, Dr. Jayagumar, office bearers of the IMA Cochin chapter, then,
screen.
can you see my slide?
Yes, sir. Yes, sir.
Yeah, now it is. Now it is visible, sir. Earlier it was another. Yeah. Now it is perfect, sir.
So, a good evening to you all. First of all, I'd like to thank the IMA Kochi for inviting me to give this talk. At the onset, I would like to say that this meeting is significant in that my co-speaker is Dr. Jayagumar. We were contemporaries in Kottayam Medical College. And as you know, he's one of the most eminent cardiothoracic surgeons in our state. And he is the ideal person to speak on the therapeutics of aortic dissection. So as you know, aorta is the largest artery in the body. The name aorta was coined by the Greek philosopher Aristotle. It originates from the Greek word aorte, which means what is hung up. He thought that the heart was suspended from this main vessel. So hence the name came aorta. So aortic dissection is a life-threatening condition characterized by tearing of the aortic wall, creating a false lumen that can compromise blood flow to the vital organs. Because you know that the blood supply to most of the vital organs come directly from the aorta. It typically presents a sudden severe chest pain or back pain. And it can lead to catastrophic complications such as organ ischemia or aortic rupture. The mortality in dissection of aorta. In the first hour, we suppose that there's 20% mortality. In the next 6 hours, it increases to 30%, 12 hours, 40%, and 24 hours, it is 50%. So 1 out of the 2 patients with aortic dissection will pass away in 24 hours, unless you do something. Survival is a right for every human being. In dissection of aorta also, we should survive to keep the life of the patient. And we have to know the chain of life in aortic dissection. It starts with the initial suspicion of aortic rupture by the first medical contact, followed by quick diagnosis, early stabilization, and definitive therapy for the patient. The definitive therapy, the suspicion should be by the general practitioners, emergency medicine practitioners, physicians, all specialists, be it gynecologists, dermatologists, radiologists, etc. We may encounter a patient of dissection. Unless we suspect dissection, it is easily missed. And the most definitive therapy, best therapy, is given by the cardiothoracic surgeons. So suspicion is the most important thing in the chain of survival in aortic dissection. From my talk, if I could instill what are the things you should suspect, things by which you should suspect patient is having aortic dissection, I think my job will be done by that time. Because when you suspect aortic dissection, you should plan the patient to be transferred to a cardiothoracic surgeon or a cardiothoracic center. An important point to note is that we should transfer the patient to such a center which has a 24 hours operating ICU, full-time cardiothoracic surgeon, cardiologist, and if there is a good program of aortic dissection repair, that would be good. We should not send the patient to a small place where there is no cardiothoracic surgeon as a permanent staff. Coming to the etiopathogenesis. One of the most common risk factors for dissection of aorta is hypertension. Hypertension, due to its mechanical stress, shear stress, will accelerate the medial breakdown and lead to dissection. We have another thing called the bicuspid aortic valve. Normally, the aortic valve has 3 cusps. In some patients, due to a congenital malformation, these patients have only 2 cusps. These patients have an aortopathy in addition to this bicuspid aortic valve, making them susceptible for aortic dilatation and dissection. Certain genetic connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome, etc., which can produce deficiencies in the aortic wall and predispose to dissection. And we have degenerative aortic diseases, atherosclerosis, and aortic aneurysms, which again can predispose to dissection of aorta. Rarely, one congenital heart disease, coarctation of aorta, can predispose to dissection of aorta. Pregnancy has been reported in some cases, they have been reported in pregnancy. And of course, as enthusiastic cardiologists, we may produce the iatrogenic dissection due to the TAVR, aortic angiogram, etc. So we'll come to the classification of aortic dissection. The most common classification is the DBakey classification, the type 1, 2, 3. Both the ascending aorta and the descending aorta is involved. Type 2, only the ascending aorta, and type 3, the descending aorta. We have the Stanford classification. The type A involves the ascending aorta, and the type B involves the descending aorta. This is important in the therapy. In the next few slides, I'll be talking about type A and type B. Type A means the ascending aorta is involved and it is very catastrophic. Type B, descending aorta is involved. We have the classification of dissection of aorta based on the time frame. We have the acute dissection, that is symptoms started within 1 to 14 days, subacute patient had the symptoms 15 to 90 days and chronic more than 90 days old. In addition, if the patient had come within 24 hours, it is called hyperacute dissection of aorta. Clinical presentation is the most important thing which I would like to talk today. The patients have very severe chest pain at the onset. It is tearing in quality. And the patient may have interscapular pain. Patient may have flank pain. Patients may experience numbness, tingling, pain, and weakness of the extremities due to reduced blood flow to the extremities. And in addition, because of the reduced blood flow to the brain, patient can present with syncope, patients can have altered mental status, patient can have focal deficits like TAA or stroke. And rarely patient can have hemoptysis. So neurological manifestation include CVA, altered mental status, and tingling and weakness of the extremities. So how do you differentiate between a pain of myocardial infarction and pain of dissection? Because both have severe chest pain. The pain of myocardial infarction is more common because myocardial infarction is a more common disease than dissection of aorta. The pain, once it starts, it steadily increases and reaches a plateau. Whereas you have dissection, the pain is usually maximal at the onset. It is like something somebody has hit you. Sudden, severe pain at the onset. And it is a tearing pain. Whereas in myocardial infarction, you feel a heaviness in the retrosternal area. Some weight has been kept on you, as if some weight has been kept on your chest. Whereas dissection, it is a tearing pain. The pain in myocardial infarction can radiate to the arm, left arm more than right arm, to the throat, jaw, etc. Whereas dissection, an important site of pain is, in addition to retrosternal area, is the interscapular pain. It's a very important feature of dissection. It almost indicates that the descending aorta is involved in the dissection. So if a patient with acute coronary syndrome with chest pain comes with severe chest pain, usually you suspect an acute coronary syndrome, especially myocardial infarction. But if the patient has a maximum pain at the onset, the patient has a tearing type of pain, interscapular pain, then you should suspect dissection of aorta. Unless you suspect, you will not look for the signs. The most common sign of dissection of aorta will be asymmetrical pulse, asymmetry in pulses. If you suspect dissection of aorta, you check both its radial pulses. Normally, both the radial pulses should be equal. If there is asymmetry, it indicates there's something abnormal. You can check the carotids. If the carotids are asymmetric, the one pulse is feeble, again, you suspect dissection of aorta. And you can measure the blood pressure in both arms. Normally, the blood pressure difference in both arms should be less than 10 millimeter of mercury. If it is more than 20 millimeters of mercury, it indicates a significant problem, either dissection or an obstruction to the blood flow to that arm, like atherosclerosis of the origin of the subclavian artery. Many patients have hypertension. Then, if you auscultate, these are the simple signs which any doctor can elicit if you have a suspicion of dissection of aorta. That is the most important message which I would like to deliver. It is very easy. No learning is required to check for the pulse and the blood pressure. By this, you can diagnose probable aortic dissection. And if you are more enthusiastic, you can auscultate the patient. If there is an aortic dissection, ejection click, it indicates that there is a bicuspid aortic valve, and patients with bicuspid aortic valve have a predisposition to dissection of aorta. Aortic regurgitation murmurs, early diastolic murmur of air is seen when you have ascending aorta dissection. It may be difficult for non-physicians or cardiologists to pick up this murmur, but it is good if you pick up. But the most important thing which I would like to emphasize today is to look for the asymmetry of pulses, asymmetry of the blood pressure, and hypotension. in a patient with chest pain having the features of dissection of aorta, which I already mentioned. So what are the red flags by which you suspect dissection? When a young hypertensive comes with a chest discomfort, maybe in the 35 or 40 years of age, without diabetes, you should suspect dissection as a differential diagnosis in addition to CAD, coronary artery disease. If the patient is having a tearing chest pain, maximal at the onset, the patient is having interscapular pain, chest pain and abdominal symptoms, chest pain and transient ischemia attacks, neurological signs, and abnormal lower limb paresthesia. Patient will complain of severe paresthesia of the legs. If that is again, thing of dissection of aorta. If the patient is tall, that means patient may be having Marfan syndrome. If the pulse that is on examination, patient is tall, pulse is asymmetry, lower limb pulses are weak, and there is hypotension, and there is a difference of blood pressure in the two limbs. These are the points by which you suspect dissection of aorta, and you should channel the patient to a cardiothoracic center where early investigations and definitive management can be taken. What are the complications of aortic dissection? In the heart, it can lead to cardiac tamponade. It can produce acute aortic regurgitation that can also lead to heart failure. It can produce myocardial infarction because the dissection may involve the root and can tear the origin of especially the right coronary artery and lead to inferior wall myocardial infarction. So these are the common cardiac complications of dissection of aorta. The non-cardiac other complications include stroke, paraplegia, renal failure, bowel ischemia, later the lower limb ischemia leading to amputation of extremities. In the end, multi-failure, organ failure will occur leading to death. So most of the organs can be involved in the dissection of aorta. So the perfusion of different organs can be involved. That is called the malperfusion syndrome. The heart can be involved. I told you earlier, the right coronary artery is more commonly involved in the dissection. Can produce electrocardiographic changes of ischemia or infarction, especially inferior wall myocardial infarction. Troponins can be elevated. When the blood supply to the brain comes down, can have stroke. When the spinal cord artery is involved, can have paraplegia. When the mesenteric artery is involved, you can have abdominal pain, liver ischemia, and renal involvement can lead to acute renal injury, oliguria, and the extremities, if it is involved, it can lead to paresthesia, etc. Some numbers are often quoted. In a dissection of aorta, coronary ischemia is noted in approximately 10%. Neurological deficits occur in 20%. Pulse deficit occurs in 30%. And audible AR murmur is noted in 40%. And 70% of the individuals with aortic dissection have a history of hypertension. So what are the investigations you'll do? The most important thing is to fast track the investigation. Even before investigating the patient, you should, and if you are sure, you should alert the cardiologist and if possible the cardiothoracic surgeon that you have a possible case of aortic dissection at hand. An ECG should be taken to rule out myocardial infarction because as in ascending aorta dissection, inferior wall myocardial infarction is common. Chest X-ray, not usually done, but if you have a chest, somebody has taken a chest X-ray, can show a widened aorta or a pleural effusion. Blood tests, troponins can be elevated, D-dimers can be elevated, blood count should be done. Renal function tests may show elevated creatinine because of renal ischemia. Elevated lactate levels can occur due to tissue ischemia, especially the lower limbs and mesentery. But the important point is that don't wait for any investigation. Go for as early as possible, go for the definitive investigations like CT scan and echocardiography, including transesophageal echography. D-dimer is a common investigation which is done. It can be elevated because there is a thrombus in the false lumen. A D-dimer, a low level has a high level, a low level is a high negative predictive value. Chest X-ray, you can see there is widening of the mediastinum, and you can note there's a calcium in the aortic knuckle. When the difference between the outer part of the aorta and the calcium is more than 10 millimeter, you should suspect aortic dissection. There's an important thing in investigation. But as I already said, don't waste time on chest X-ray. CT scan is the most important diagnostic facility available. Should be taken as fast as possible. It's the first line imaging modality in most cases due to high sensitivity and specificity and ease of rapid acquisition. It will show the images of the aorta, including the intimal tear, true lumen, false lumen, etc., which are important for the surgeon. And complications, of course, and the branch, which are the branches involved, the carotids, the subclavian, the celiac, the mesenteric, the renals, the lower limb, etc. Transesophageal echo is another important investigation. That is when the patient is waiting for a CT scan, can do a transesophageal echo. You have a good idea of the ascending aorta and the arch and the descending thoracic aorta. You can see the false lumen and the true lumen and the tear. Can see the decision. Can see the flow in the true lumen and the false lumen. Rarely you may see pericardial effusion, the case of ascending aorta dissection. MRI scan is another important investigation that will give a clue, but it takes time. It gives good images, but MRI scan takes time. So you should not waste time to do an MRI. Medical management, urgent stabilization of the patient is very important. You should admit the patient to ICU if you suspect aortic dissection. The most important thing is aggressive blood pressure control and heart rate control, because it is the blood pressure that is driving the tear of the aorta. If you lower the blood pressure, the tear will come down. At least the tear won't progress. And ask for immediate evaluation by cardiovascular specialists, including the cardiologist and the cardiothoracic surgeon. The target hemodynamics, the blood pressure, systolic blood pressure will be less than 120 and a heart rate of less than 60 to 80. The medications used to lower the blood pressure include metoprolol, esmolol, labetalol, all given intravenous for quick action. If the blood pressure is not controlled with the beta blockers, you can give sodium nitroprusside. And analgesics like morphine or fentanyl should be given for pain control. The definitive treatment of aortic dissection depends on whether it is a type A or type B dissection. Type A dissection means the ascending aorta is involved. Type B, it is a descending aorta. Type A, the therapy is open heart surgery. You give to the surgeon without wasting time. Type B, you have time. In complicated cases, you have an interventional procedure called the TIVA. And uncomplicated cases, medical therapy may be sufficient. So what are the high-risk features in uncomplicated type B dissection? When you have refractory hypertension, when you have refractory pain, when the maximal aortic diameter is more than 40 millimeters, when the false lumen diameter is more than 20 millimeter, entry tear is more than 1 cm 10 millimeter, tears on the lesser curvature, etc. These are all different points. You think that it is a high-risk feature, then you have to intervene. One interventional management is a TIVA. You have TIVA stents to insert in the aorta. Indications include malperfusion syndrome, intractable pain, rapid enlargement of the aorta, impending or frank aortic rupture. So what is this TIVA? It is a covered stent. You know that the stents, coronary stents, these are metallic scaffolds. In TIVA, it is a covered stent. In addition to the metal, you have a membrane so that you will cover the interior of the artery. It is introduced into the arterial system through the femoral artery at the groin. You puncture the femoral artery at the groin, put a large sheath, and you introduce this stent, which is mounted on a balloon. Take it under fluoroscopic guidance to the site of implantation. You should decide on the CT where it should be implanted. At that particular site, most commonly just below the left subclavian, you inflate the balloon and the stent gets deployed there. The balloon is then deflated and removed, just like a coronary stent implantation is done. Sometimes a second or third or fourth stentograms may be required. These are telescoped in the early stents. And the definitive surgical management will be dealt with by my Dr. Jayagumar. Over to you, Dr. Jayagumar.
Thank you. Thank you, Hype sir. I'll start sharing my screen. 1 minute. I think, yeah. So by the time I just said am I audible?
Yes, sir.
Yeah.
Loud and clear.
Yes, sir.
Yeah. Yeah. By the time I'll just see this. Okay. My screen is visible now.
Yes, sir.
Okay. Yeah. Actually, thank you, Dr. Matthew, for the eloquent presentation. It was really very clear, and we could see how he could express and how he could convince the importance of early referral and early detection of cases. So I always appreciate, he was one of the seniors in Kottayam Medical College, a very good, excellent academician, and very, very good clinician. So thank you, Aib sir, for the excellent discussions, excellent presentation. So that my job is also quite easy now. Now I think I will concentrate more onto just getting the presentation. Yeah, more onto the management part rather than the clinical and other aspects. So acute aortic dissection. And before starting, let me thank the IMA Kerala State Branch, especially Dr. Deepa Agustin, the president, and the IMA Kerala State branch leaders, as well as the office bearers, for inviting me for this lecture. And actually, the aortic dissection is a race against death. That means surviving a tearing aorta is something very important, because many things has to fall in time and in place, so that you will be able to, somebody should be able to diagnose it, and you should be able to reach the particular center, and everything should be ready in that center, so that in a time-bound manner, everything should happen, then only the life is saved. So I think this time I will concentrate more on the management part and rush through some of the initial aspects. Already, Dr. Matthew has discussed about the aortic dissection, what it is and how it is formed. And these three acute aortic syndromes are very important. This is a picture I have taken from the ACS ACCHA guidelines 2022. And in aortic dissection, what we see is the true lumen is compressed, and the false lumen is there, and there's a tear, and the hematoma is formed, or the blood is passing in the false lumen. Whereas in an intramural hematoma, it's a low pressure system. The true lumen remains the same, and there's this collection of hematoma in the outer wall, or a penetrating atherosclerotic ulcer, which is again another acute aortic syndrome, where atherosclerotic plaque has ruptured, causing a small hematoma, and plaque must be restricting the flow of blood into the media or the adventitia, so you will get a hematoma around. So these are the three acute aortic syndromes which come across, out of which we will be discussing acute aortic dissection. Of course, which is a catastrophic disease of the aorta, the etiology, the age group, All these things were discussed in detail. And as Dr. Matthew was rightly pointed out, high index of suspicion, rapid diagnosis, and timely intervention can be life-saving. So this classification has already been discussed. For the surgeon, we depend mostly on the type A and type B, that is the Stanford classification, to decide on the management part, because type A always goes for a surgical intervention, whereas type B, as already has been discussed, goes for a medical or a EVAR or a endovascular management. Of course, high index of suspicion, this was already discussed. And we depend mostly on the CT for the diagnosis and management, planning the management. So CT will tell you where exactly is the intimal flap, where is the ascending aorta is involved, whether it is extending to the arch, and whether there are secondary tears in the arch, and what is happening with the distal aorta, and what all things are coming from, what all branches are coming from the true lumen, what all branches are coming from the false lumen, and whether it is leaking outside. So many informations we get from the CT. So CT is something which is very, very important in not only just for diagnosis, but also for planning. Of course, patients who comes in a very unstable situation, we may push in and do a TE to confirm and then go ahead surgery. But whenever a patient is diagnosed in the periphery, it's always better to have a CT aortogram done or CT done, so that we will be able to just take up the patient as early as possible. Now, what is the goal of treatment? Of course, in a type A aortic dissection, it is to prevent aortic rupture, which is a catastrophic thing, and then prevent retrograde extension of the dissection into the aortic root. Means if there's a retrograde extension into the aortic root, two things can happen. One is aortic regurgitation. Second is the coronaries can get involved and acute myocardial infarction can happen. So that lead on to, say, acute LV failure. Whereas antegrade propagation result in, of course, the organ ischemia, maybe in the form of spinal cord paraplegia, or maybe mesenteric, renal, or lower limb ischemia. And the most important goal is to alleviate these malperfusion syndromes if it happens. And the strategies which you take in planning the management is complication specific. And what are the risk factors for surgery? And the risk factors, when a patient comes to you, if the patient is in shock, or tamponade, then of course it's going to be high risk, because the tamponade patient, you have to put on a peripheral cannulation and then only open the pericardium. Otherwise, sometimes the patient may just bleed to death the moment you open the pericardium. Then the shock may be due to, of course, coronary involvement or rupture outside, which is again one of the bad prognostic factors. Then neurological or visceral malperfusion, because neurological malperfusion, okay, and a stroke due to ischemia is okay, but if it's a hemorrhagic stroke, then we are worried. So most of the time it is an ischemic stroke, and if the brain is still preserved, we may be able to go ahead and do it. And visceral malperfusion, out of which, if you look at the mesenteric malperfusion, if there is mesenteric ischemia, we are really going to have trouble, and the mortality rate may go more than 50% if you don't intervene in time. Then preoperative myocardial ischemia due to coronary dissection is also a risk factor for surgery. And of course, many times patients are old, very old, or maybe having renal failure, POBD, peripheral occlusive disease, and so many other comorbidities, or very bad lung. So those things also can add on to the risk in such patients. And maybe some of the cases which maybe from the periphery, there may not be any point in referring the patient, because many a times we may get a patient 85 or 90 years old, frail, with bilateral bullous disease, or patient was bedridden for such a quite long time. All these things, all those patients, even if you refer, we may not be able to take up the case because it is prohibitive mortality in those cases. And then, but even if there's a new onset hemiplegia, it is not an absolute contraindication, even though sometimes we may land up with some neurological deficit. And paraplegia, the chance of spinal cord deficit improvement is low, but still the patient can go back live. We will get a live patient back. This is again from the 2022 guidelines, AHA guidelines. So the medical management already Dr. Matthew has said, and out of which the most important thing we feel is, so if you stabilize the patient medically and bring the patient in a better shape to the surgery in the operating room, because once the patient comes to the center, we have to take them up urgently because every hour lapse this increases the mortality by 2%. So for us, it is important to push into the theater at the earliest. But still, if there's a delay or if the patient is referred from periphery, say putting an IV line and then starting some beta blockers, esmolol, or say even the BP is high, sodium nitroprusside, but in transit there should be facilities to monitor properly so that the BP is controlled, the heart rate is controlled, the dissection may not progress or the dissection may not rupture, so that the patient, you may get the patient in a better shape so that the outcome will be better. So controlling the BP, controlling the heart rate, and keeping the patient comfortable with proper medications is something very, very important during transit. And hemodynamic instability. So if the patient is hemodynamically unstable, we have to suspect free aortic rupture or intrapericardial rupture with tamponade or acute LVF. Acute LV failure occurs because of the acute aortic regurgitation. And in that case, you may not get the typical aortic regurgitation marker, but you may get features of pulmonary edema, and it could be also due to coronary compromise. All these needs just push the patient into the theater. Nothing else is going to save the patient at this particular point. And suppose you detect malperfusion syndromes like, say, mesenteric malperfusion or renal malperfusion or lower limb malperfusion, then there's a question like just now taking care of, because in aortic dissection type A, you take care of the ascending aorta. You don't do anything with the abdominal or lower limb abdominal aorta, basically because it is almost technically very, very difficult or impracticable to just go for a total aortic replacement or anything in that situation. So how to once you take care of the ascending aorta, most of the time, say the distal malperfusion will get settled. But if you have a very, very aggressive interventional center, which we have right now, Dr. Ashwin and our radiology department is doing so, if we have a very good, say, interventional radiology backup or maybe cardiology backup, we can definitely plan for interventional thing in the first phase so that the mesentery and the kidneys and the lower limb gets revascularized, and then do the ascending aortic repair as a second stage. So this is what is happening. You can see, say the interventional radiologist can puncture and produce a secondary tear somewhere down, so that the mesentery, kidney, everything gets perfused, and then so you get a patient in a better shape to the theater. And during surgery, when you're on cardiopulmonary bypass, at least those organs will get perfused. It can do the other way also, depending upon the facility you have. Of course, in the preoperative management, it is a comprehensive monitoring is needed. So we need to put an arterial line, or maybe two arterial lines sometimes, because the peripheral and femoral is needed. And then the central venous catheter is important. And then, of course, all this non-invasive monitoring, including urine output, and then neurological monitor. And in our center, we always go for a NIRS monitoring whenever we take up a patient for acute aortic dissection surgeries, because there is something very important, because you go on deep hypothermia and circulatory arrest, where it is very, very important to do that. And once you have decided on surgery, what are the things that you will do? Once there is a dissection, type A dissection proximally, that is the aortic root, you have to do something at the aortic root to clear that. And then say, of course, the point of entry in the ascending aorta has to be, or in the sinus has to be taken care of. And distally, the aortic arch or distal aorta, you have to manage that also. So these strategies you have to plan depending upon the CT findings, the extent of dissection, the entry tears, whether there is this distal ischemia and all. So based on that, you plan. And what are the things done proximally? That is the aortic root. You can do a root replacement, which is a Bendal operation, or you can preserve the valve and do a root repair, that is David operation. And if the root is not involved, then you can just put a supracoronary ascending aortic replacement. And then, of course, you have to decide whether the arch or the descending thoracic aorta needs to be addressed. So you say, look at the root. The root has the virtual basal ring, then the ventricular aortic junction, then the sinuses, and of course the commissures and the leaflets and sinotubular junction, and you can see the ascending aorta here. So if you look at say the aortic root, if you want to manage, uh, if the dissection has involved the root, either the patient will have aortic regurgitation or the patient can have a coronary ischemia. So whatever is there, when you do something with the root, you have to replace the entire root. That means the valve is replaced, the ascending aorta of that, the sinuses are replaced, and then the coronaries are reimplanted. So that is called the Bendal's operation, where you replace the aortic valve, the sinuses and the aortic root, and reimplant the coronaries. So this is a Bendal operation where you can see the entire aortic root is replaced and the coronaries are reimplanted. Then the next procedure we can do is the David operation, because a patient may come with a discharge summary of a David operation. That means the difference is here the root is again replaced, but you are preserving the valve inside the root. That is the new, with a vascular graft, with a sinusovascular graft or a straight graft, you replace the root from the virtual basal ring to the sinotubular junction and reimplant the coronaries. But we are keeping the valves inside. The advantage is you don't have a prosthetic valve. So you need not worry about prosthetic valve degeneration if it's a bioprosthetic valve, or you put a mechanical valve, you don't have to worry about anticoagulation in such patients. So that is the advantage of a David repair over a Bendal operation. Then the other is supracoronary ascending aortic replacement. If the root is not involved, the coronaries, the sinuses, the leaflets are intact, then just replace the point of dissection. This is one of the easiest surgery and maybe very life-saving in a patient with aortic type aortic dissection. Now you have to manage the distal portion. If there is no separate entry tear in the arch, you can go for either just stop short of the arch, just like a supracoronary, or go for a hemi-arch replacement, preserving all the arch vessels. And if you get a separate entry tear in the arch, then of course you have to go for an arch replacement along with the ascending aorta. It may be a Bendal or David in the root, and then an arch replacement where you can do. Suppose it goes further distally, and if you feel that there is distal malperfusion and you have to address the DTA also, you have the frozen elephant trunk, whereby you can pass a stent into the distal aorta through the graft, which is made, which is custom made, so that you can push that into the distal aorta, descending aorta, and take care of that. So depending upon the extent of the disease and aortic valve or root involvement, you may be doing a Bendal, you may be doing a David, you may be doing a supracoronary, or going into a hemi-arch or total arch or a frozen elephant trunk, depending upon the particular situation you have. And for any arch surgery or any ascending aortic surgery, you have to stop the heart. So cardiopulmonary bypass is very, very important. So in establishing cardiopulmonary bypass in a dissected aorta is always challenging. So the aorta is bad, so most of the time we go to the peripheries like the femoral artery, axillary artery, or carotid artery, so that you will be able to establish get an arterial inflow, and then you can of course take out the venous blood either from the right atrium or from the femoral vein, depending upon the situation. And once you are on cardiopulmonary bypass, almost always you are doing the distal anastomosis, that is in the, whether it is a supracoronary or ars, whatever it is, you are doing those anastomosis without putting a clamp in the aorta. That means you have to stop the entire circulation of the patient. That is called deep hypothermia circulatory arrest. So you will go for 18 to 24 degrees centigrade, and in an acute aortic dissection, we always go down to 80 degrees centigrade, and then stop the entire circulation and do the distal anastomosis. So when you're doing like that, you're worried about organ perfusion. So you have the brain, you have the distal organs, so it is, you have the heart. All those structures we have to protect. So to protect the brain, of course, at deep hypothermia and circulatory arrest at 18 to 24 degrees centigrade, we get around 30 minutes to 1 hour. Without any circulation, the brain will be protected and the patient will come back without any neurological deficit. And then in addition to the during that period, you can have some brain circulation by technique called antegrade cerebral perfusion or retrograde cerebral perfusion, which we rarely use in a dissection, but we may use in a routine aneurysms, because in a dissection we always go for an open arch repair where the clamps will not be applied, because any clamp in the distal portion is going to damage the intima and you can have an aneurysm at that particular point again. So cerebral protection is one thing in any dissection or any heart surgery or any aortic surgery. And the second is this is deep hypothermia circulatory arrest. You stop everything, no circulation, no breathing. Okay, and the cooling has its own problem like glacial problems and rewarming, but centers which do it routinely, this is safely managed. And this is the selective antegrade cerebral perfusion, which mostly used in other situations like acute arch aneurysms, where you cannulate the axillary artery, and when you stop the circulation to the entire body, the brain alone is perfused. So from the axillary artery, the blood goes to the brachiocephalic artery, and then it go back to the right common carotid, and the brain is perfused to the circle of release. So that is one thing. And the other is from the SVC, you can give the superior vena cava, you can give the blood back into the brain and protect the maintain some perfusion during circulatory arrest. So these are brain protection strategies, out of which maybe the retrograde is not very popular, but can be used if you feel in aortic dissection, if you feel that you're going to take a lot of time. Then, of course, the heart has to be protected, especially if you have a coronary problem, or if and since you are stopping the heart for quite a long time, so you always use myocardial protection techniques, which is hypothermia, local ice flushes, as well as St. Thomas or one of the cardioplegia solution, which is a high concentration potassium solution. And now, if you have a normal aortic leaflet before dissection, then the mechanism of dissection is just some mural hematoma displacing the sinotubular junction and attachments and producing a deformity of the leaflet, leading to aortic regurgitation. Such cases, you can just do a supracoronary thing like this, where you can approximate the the dissected flaps with a Teflon felt on either side so that the aortic valve is resuspended. You don't have to do anything with the coronaries here, and then put a graft over that to take care of the point of dissection. So a scar, that is supracoronary aortic replacement, is done. So this is a small video. You can see the aorta in an acute aortic dissection. So it is red, inflamed look, and it's a very, sometimes it may be the moment you touch it, it is going to bleed like anything. And already the cardiopulmonary bypass is established, either with say an axillary artery cannulation for the arterial flow, and the venous blood. You can see that the one which you see down with that metallic thing is the venous cannula, which is taking out the blood from the right atrium and then giving back at the aortic root somewhere in the right axilla, which is not seen here. So this is an acute aortic dissection. And now you see, now we have put a clamp there to stop the heart. Now you see the root is all dissected with thrombus, and that is the intimal flap around. And now you can see the leaflets which are good. Now you can fix this and resuspend the root by just between two Teflon felts, so that the aortic regurgitation is connected, and then a graft is sutured. So that is the uh, uh, say the how to take care of the proximal portion in a supracoronary or in a dissection which does not involve the aortic leaflet much, as well as the coronary. Now, this is the distal portion again. Say the same patient distally, you can see that the white sucker is into the distal aorta. It is into the arch of aorta. We have stopped the entire circulation. No flow is there. Now just trimming it off, and there also you will have the dissection flap extending down. Here also you put two Teflon felts on either side of the wall, and then put the anastomose, the graft, and this is a supracoronary ascending aortic replacement done in type A dissection. Now you can see here, this is the aortic root where you are putting a graft and the valve is sitting there. This is David operation, where say you can see that the valve is resuspended in a graft, so that the entire sinuses and everything is replaced. Now you reattach the coronaries into it. You can get a very competent aortic valve like this. Now you are reattaching. This is the right coronary which is being reattached. So you can reattach the coronaries, and this is the final result for a David repair. So here, that is it. Now, I think this is in more detail about a David repair. So this is aortic root which is being dissected. This is the coronary button is created. Then we have to really go down into the ventriculo-aortic junction, and we are exercising the sinuses, so that you will have the aortic valve ready, and that is the left coronary button which we have created. That is between the left sinus and the roof of left atrium. The aorta is being dissected down up to the ventriculo-aortic junction. This area is very close to your conduction muddle, and if you go further down, you may land up with a complete heart block, and the cardiology people have to put a permanent pacemaker. So this is the aortic valve. Now certain measurements are made to decide whether it is repairable and whether you can, what is the size of the graft that you are going to put. So this is from the mitral annulus to the top of the commissure. So that will give the size of the graft which you are going to use, which is very important. If you put a smaller size, the valve will get crumble. If you put a larger size, you will have aortic regurgitation. So these are subannular sutures, and this you can see that we are going down into the LV cavity, and that is a mitral valve down. So you are taking sutures like that. So all around now, so this is the graft which we are using, which is placed to resuspend the aortic valve inside. And certain these measurements are very important, because if you don't properly measure and mark and then do it, you can distort the aortic valve and end up in aortic regurgitation. So this marking is made for all the sinuses, and then you put it down. So here we don't need any valve. The native valve is being preserved. Now you can see that the valve is being resuspended inside the graft, and then it is being sutured. This is a hemostatic suture. All the three commissure pillars are being suspended, and then maybe just, yeah, so I'll make it very brief. I know So for surgeons, it may be interesting, but others they may be feeling a little bored. But this is just to show how a David repair, which is a little complex, but very good repair for the long term. So this is how it is being suspended. Then you re-anastomose the coronaries, and then of course the proximal part is also being taken care of. This is how a David repair is being done. And this is just a picture of this is today's case morning we were doing. Manu was also with me. This is actually not a aortic dissection, but in aortic dissection also we go for this the penta. The root is replaced along with the say the ascending aorta and the arch up to the subclavian, including the subclavian. So this was there's a brachiocephalic artery, which is seen as the largest one, and then you can see the left subclavian, left common carotid also. The left subclavian is not seen there. So the entire the root, ascending aorta, arch, everything may be replaced at some time in an acute aortic dissection. So this is another one video where you can again see this is some other video. So I have just put again the root, arch, everything is, and the branches are prepared on table. Okay. Now there is something called frozen elephant trunk where you can manage the arch of aorta and then push a standard graft down into the descending thoracic aorta so that you will be able to take care of the say distal malperfusions to some extent or another arterial. And later, if you have some problem distally, you can do a DTS surgery or thoracoabdominal aortic universal surgery with that. So this is just a video of the frozen elephant trunk. So this is a custom-made thing comes with very costly, which very few people who comes to our center affords. It is around 11 to 12 lakhs for this particular thing. The one which is going in is a standard graft. You can see that the standard graft portion, and beyond that bluish ring, that this is a guide wire put from the femoral artery so that you will not go into the false lumen. And the stent is going down into the descending aorta. Already the descending aorta part, you can see we have fixed it with the Teflon film. And now that the graft will be deployed into the descending aorta after removing that stent. So this is a frozen elephant trunk. Now you can see the remaining portion of his usual vascular graft, and we are anastomosing the subclavian to the one of the branches, and then all the others, the carotids and the brachiocephalic will be re-anastomosed, and this is the frozen elephant trunk operation which is being done. Type B, I think already Dr. Matthew has said, is mostly medical management. And if it is a complicated one like rupture or branch artery occlusion, malperfusion, or if there is extensive dissection, ongoing pain, uncontrolled hypertension, there is an indication for intervention, and that is mostly done by the endovascular method. You can put a stent or sometimes with the debranching, so that will take care of a type B dissection. And untreated type A, already we said that death is within 24 hours, 50% of the patients will be died. And so it is very, very important to intervene in a type A aortic dissection. And 2018 onwards data we have collected, it is more than 520 cases of aortic aneurysms, out of which I think we have around 70 plus dissections done, and which includes everything, the beta, large, all the combinations we have done with acceptable results, of course. And so to conclude, as we have said in the first presentation, early diagnosis and institution of definitive therapy is the key. Because if the patients are coming late, that is something which we find many times. They may come in hypertension for a long time. They may come with a lot of malperfusions. So we may not be able to save them. But patients coming in time, there are cases where patients is arrested just when we were examining in our corridor, but we could just send the patient, take the patient inside and save them, and minimize emergency room to over time. It's very crucial. And it is not a curative, but many a time they will come back with, say, distal aortic problems. So we may have to do interventions. And post-op is something very crucial because it is not just the ICU care, it is not just the management of hemodynamics, prevention of infection, but it is also taking them back to life, because it's very important to have, say, the social worker, the nutrition specialist, and the physiotherapist all on board to take them back to life. And serial imaging and surveillance, because a patient comes with for a follow-up, it is important to have strict BP control, and we have to do serial imaging. And we do the serial imaging at discharge, maybe at 1 month, 3 months, 6 months, 1 year, and then depending upon the situation, we may advise 6 months or yearly follow-up CT scan. And of course, if we have difficult scenarios like patients malperfusion, lower limb malperfusion, or say mesenteric malperfusion, or if you're planning for, say, David repair, those cases, of course, FET and all need specialized aortic centers, and high volume centers are important in those cases. So I think I have just gone through the different management options, and thank you for the time, and thank you for the patience. Thank you very much.
Thank you, sir. Thank you for that wonderful presentation. So the whole intent of the presentation, or especially the surgical part, was to make everyone understand that aortic dissection is not a end of the day disease anymore. We have a wide spectrum of surgical management at our disposal, depending on the clinical condition of the patient, and most of the time we can pull out the patient from a definite mortality. And like sir said, it is all about teamwork. So when it comes to a high volume center, we have a team at our working with us. They are well versed with the protocol, the ICU care, everything. So most of the time the results are better, and you'll be able to fast forward a lot of steps and take the patient into the OT at the earliest. And thank you, Jayuma sir, and thank you, Aib sir, for that wonderful presentation, because sir has, as always, like made the presentation very simple, and made everyone understand that you can diagnose an aortic dissection just by mere clinical examination and the symptomatology of the patient. And hope this will serve the purpose for everyone. Thank you, sirs, for this wonderful discussions.
Thank you.
The floor is open for discussion. If you have any questions, you may please ask our faculties.
I'd like to thank Dr. Jayuma for this wonderful video. Very good.
Yes, sir. Thank you, sir.
So most of the time the question comes whenever aortic dissection question patient comes, or like somebody calls us for most of them think that it's the prohibitive cost that comes with the surgery is what prevents them from approaching any hospital. So what is your comment about that, sir? Since we have doctors from all specialties, I think it would be.
Yeah. I'm sorry, you want to say something, or?
No, the question is about the cost for surgery. Yeah, your part.
So actually now that is something very important. Many times, no, aortic dissection was very complex surgery, and of course, a lot of consumable disposables are used. And say the most important thing is ICU stay can be prolonged, especially in complicated cases. So every day in the ICU is going to cost the patient very high. So government sector, for us, the cost is like now around 1.5 lakhs for the surgery, and ICU, of course, many times we will be able to support. So in a very complicated case, which goes for a CRRT, or say prolonged ventilation, tracheostomy and all, the cost may escalate in the government sector also to some extent to the tune of 3 to 5 lakhs, but otherwise it is quite the same. But sometimes what happens is in the middle of the night, patient will come without anything, but we have to operate. We will find out some resources and do it all, rather than waiting for them to arrange the money. We are forced to do. Young patients coming, and then so we always keep some reserve from something or other. That is how we manage.
Okay, sir. Thank you, sir. There are no more questions. I think we'll call it a day, sir.
Thank you.
Thank you, Dr. Matthew and Jakumar sir, for that excellent presentation. Our senior IMA leader, Marthandavilla sir, is there. Sir, Marthandavilla sir. I don't think sir is there. So, Menon sir?
Yeah, nothing to add. It's a wonderful session. I was listening. And thank you, Dr. Matthew and Dr. Jayakumar sir. Wonderful presentations. It's I think you have opened a window as far as this is concerned, latest informations. Thank you very much. That's all. Thank you very much.
And it is important to know that our government medical college, Kottayam, is doing so many surgeries at low cost, and this should be an awareness session for all the doctors for early diagnosis and early referral also to such centers. And now we'll come to the end of the
I
session.
think people like Dr. Jayakumar sir should be actually introduced in a better way. He is very famous, and you know that. Of course, most of us know him, but the services they are doing in the public health sector is wonderful. Thank you very much.
Yes, sir.
Thank you, sir.
Before I could introduce, sir took over the session, so that's why I couldn't talk
It's
more
okay.
about it.
Most of us know. Yes.
Yes, sir.
Yes, sir.
Yes, sir.
So for formal vote of thanks, let me invite AMS Secretary, Dr. Vinod Nair.
You know, this is an IMA Kerala State Branch webinar, sir. IMA Kerala State Branch has two academic wings. One is the Academy of Medical Specialties, and other is IMA College of General Practitioners. The AMS state program. Matthew sir said it's a Cochin IMA program. It is not. It's a state program. Thank you.
Okay. Sorry, I thought it was a coaching program. Okay. Thank you.
Marthandavilla sir is saying something.
Then just go for the vote of thanks. Don't waste time. Vinod is not there. Vinod? If Vinod is not there, Deepa can propose the vote of thanks.
Okay, sir.
Finish it.
Anyway, I am a Kerala State Branch AMS chapter is privileged to have these two eminent speakers today. In spite of their very busy schedule, they readily agreed to take up this session and presented in such an excellent manner. Dr. Matthew introduced the session in such a simple manner that it is easily understandable to all the doctors present here. So I would like to thank Dr. Matthew Aip for that session. Thank you, Aip sir. And Dr. Jayakumar also, in spite of his busy schedule with surgeries all day, he readily agreed, and he was busy last week traveling. In spite of that, he took up this session and he presented in such an excellent manner so that we all can understand that so many procedures are being done in our government setup. And it should be an eye-opener for each and every one of our medical fraternity to identify such rare conditions and also timely referral. Thank you so much, Dr. Jayakumar sir, for your sparing your time and spending time with us. Thank you so much, sir.
Yes.
And thank you, Dr. Manoop, who is a young, vibrant cardiovascular and thoracic surgeon of Government Medical College, for ably moderating this session. Thank you so much. Thank you, Menon sir. Thank you, Menon sir, for inaugurating our session, and always sir is with us for all our webinars, supporting us and supporting AMS for in all our activities. Thank you, Menon sir. And thank you all the doctors who have joined the session and all the state leaders and branch leaders and all other doctors who have joined this session. Thank you so much. And have a good night. Thank you.
Good night, everybody. Thank you.